I would like to welcome you to our webinar today. My name is Brian McKenna. I'm the Deputy Director of the Reproductive Health Supplies Coalition. It's my pleasure to welcome you to the System Strengthening Group Working Group webinar titled Policy Determinants of Modern Contraceptive Prevalence Rate. Presenting today are Dr. Michael Cohen, the Monitoring and Evaluation Director for the Global Health Supply Chain Program, Procurement and Supply Management Project, or as we know it, GHSC-PSM project, and Suzanne Gold, the Monitoring and Evaluation Specialist at GHSC-PSM. They will be presenting on the methodology and findings of research into outcomes of FP policies implemented globally over the past decade. As we'll see, their study identifies which among the assessed policies are most likely to lead to the desired outcome of high mCPR among married women of reproductive age in selected low and middle income countries. Dr. Cohen and Ms. Gold will take us through their presentation. We'll then have an opportunity for questions and discussion. If you have questions as they present, you can put them into the chat. If they're absolutely burning questions and you just need them to be answered, put maybe an asterisk just before the text, and we'll try to get to it as we go. If not, we'll answer those at the end of the presentation during the discussion and Q&A session. So please, just a reminder to keep yourself on mute so that everybody can hear clearly. And with that, I'll turn it over to Dr. Cohen. Dr. Cohen, over to you.
Muted, and now I'm not muted. Thank you, Brian. All right. Well, welcome everybody. You know, I was just thinking if it's easy to do, maybe also if you can put your organization in your name. Be interesting to know who's here. What we're going to present here is, say, top-line research. This is really brand new. We trusted enough to bring it out to you, and we're excited by it. But you know, when we come back in a year, I'll bet some of this has changed. I'll put it that way. So you know, but we really think some of it's really strong enough to bring to you now. All right, let's start. The first slide. Suzanne, please. I feel like I want to hear that beep. Like I'm old enough to remember the slide. What are those? The film strips in second grade.
All right.
Can you move it forward?
Takes a little bit to move forward the first time. Let's see.
Just the first time?
For some reason, it I don't know why.
All right, we'll figure this out, guys. It's going to move.
Another trick.
All right, well, as this is coming up, I'll start here. Look, I think I can do it without that. As we all know, modern contraceptive rate, or mCPR, or now it's just modern contraceptive prevalence, and even that comes in and out of sort of where it stands in the priority of contraceptive indicators. But this is a key statistic. It's measured periodically at the population level, often through the Demographic Health Survey at DHS, and it's a relatively simple indicator, right? The percentage of women of reproductive age who are using or whose partner is using a modern contraceptive method at a particular point in time. So why do we care so much? We care about this because the indicator is directly related to reductions in unwanted pregnancies, which leads to reductions in maternal and child deaths, and say unsafe abortions. So therefore, as a key diagnostic of this system, we don't just want to monitor this. We want to actively, strategically promote activities that are going to make it rise. And to do this, we need to understand the dynamics of it, not just at the individual level or even regional, but we think it's important to have insight into the levers that can affect it, to identify the mechanisms, right, that will influence it and not just track it. Next slide. So where are these primary nodes of influence for this? For when we look at contraceptive security, and we'll define that in a bit, but if you look at this is not a scientific map of the system, but think of this more as, well, kind of my brain map to see, where we see big policy being implemented, where the effects might be. And there's quite a bit of evidence at the distal end of this system, towards the right side. Decision makers have useful guidance available that provides, for instance, the demographic attributes of clients, right? As well as attributes of successful community-based programs that provide the commodities, training, advocacy, all of this to potential clients. But our focus, and what we'll speak to today, is directed more at the other side of the system, the left side here. And specifically, we asked what national policies successfully drive the contraceptive prevalence. And we have the, up to through the ministry, central governments, and this can be extended even to international organizations, UN and other donors. Next slide. So we started down this path with an intentional purpose, and that is to provide targeted evidence-based guidance to governments looking to improve health outcomes, to donors that want to prioritize reproductive health activities, and hopefully without sacrificing impact, right? There is a lot of evidence, as I said, and we're familiar with that. What attributes of individuals are influence the likelihood, say, of using contraceptives? So, for instance, well-proven attributes, age, income, education, others. And so there's been a lot of work or some work in recent years, for instance, by Avenir and John Stover, Michelle Weinberger, investigating the relationship between, say, product diversity, choice, mCPR. So that we have towards the left there. And most of the work, even within that area, is focused on a country and frequently just a subnational region. So we went about this in a different way, and what we'll show you here. And this was possible because of USAID support for over a decade of the Contraceptive Security Indicator Survey. And specifically, our recent effort to develop a harmonized data set that integrates and standardizes all of this data into a single validated set that has now 62 countries and 230 variables. And so with the work of establishing this rich data set under our belts, now we're in a position to refine these hypotheses and query the data set. So first, we're going to show you evidence of which national policies that we've been measuring are most likely to lead to a higher mCPR. And following this, we'll take it one step further, narrowing that focus to one of those successful policies and ask again, what upstream policies led to that policy being implemented successfully? So spoiler alert, we'll be homing in on product diversity, method mix, which is an important lever. As I just mentioned, John Ross, John Stover, and almost 10 years ago, provided evidence that having this mix of methods can lead to a better, higher mCPR. We again corroborate that and then try and ask, well, then how do we get to that method mix if that leads to higher mCPR? Next slide. So let me just go over briefly some methodology, and if we have questions on this, we can come back to it. Next slide. So we use mathematical modeling, and very briefly, a model, just keep this real simple. It is just a simplified representation of a complex system, right? It is very difficult to look at a data set with 230 variables and say, what's happening? What we want to be able to do is take that and, using that data, estimate future outcomes that otherwise, as humans, it's just very difficult to get in there and do that. That is what we're doing, pure and simple. So next slide. In this case, what we're using is IBM's, you're all familiar with SPSS, most likely. We use something called SPSS Modeler, which no one's ever heard of, unless you work at IBM apparently. But IBM is a partner with PSM, and so we lucked out. And through this, we can assess the influence of over 50 policy metrics on mCPR, contraceptive prevalence, from those 62 countries in the data set. So our outcome of interest here, the dependent variable, is mCPR. And what we're looking at is a number or an mCPR that we're considering in this case to be higher, as over 51%. This is a number that Susan will explain is within the range of where USAID considers a time to start talking about perhaps changing over how they provide support. The independent variables, so what are the things that we're looking at that might influence that? Do they have committees? What do the finances look like? What does the supply chain look like? Potentially even what the laws around there look like. And the model we're using for all of you stats geeks is a binary lasso logistic regression. We've done a different types of regressions. This was most successful here. And so that provides that evidence. Next slide. And again, very briefly, we've gone through validation processes, performance tuning here. We can go into more of this later, I think. What we want to just maybe quickly let you know now that we did have this sort of iterative variable selection. We want to make sure that what we're looking at really is correlated. And for those that have done this before, we want to avoid overfitting. There's a lot of variables here, and that can sometimes get a little bit complex even for Watson. And one important thing, I think, just to jump to the end of this list, that we do have other control data in here, right? It's easy to look at this and say, well, yes, but maybe it's just because those countries that have high mCPR also are richer or have better education, and all of these things we know influence mCPR. So we also control for those. Next slide. And I think finally for me, what are the limitations? So, and when we say limitations, keep in mind, it's not sort of just the vernacular. What are the problems with this? But what can we limit this to? For instance, the focus population is married women. Okay, so that's what we're talking about. We can guess about how that might be interpreted for every other population, but for this discussion, we'll limit it to that. The complexity of this model is definitely a strength. We have the ability to look at all of these different variables at this very high policy level, which is unique. But it's also an obstacle. As I said, the complexity of the data can be something we have to be very careful about and make sure that that's not becoming a ghost in the machine, right? Chaos theory sort of reigns here, and so we want to make sure that we are understanding what we're actually getting. This data was collected over 10 years. If anybody does temporal analysis, sometimes 1 year to the next can be difficult. So we had to make sure that even though we had different respondents, different questions, that we were able to harmonize this and compare apples to apples, even when the survey questions can change over the year. And so our harmonization process went through a transformation process with the data to make sure that it was comparable. Next slide. Okay, and before I hand it over, some of the data sources that we're using, there's the Contraceptive Security Indicators Survey that Suzanne will go over briefly before we get to our results. It's a really powerful survey. And we also include some secondary data through UN organizations, World Bank, I think UNFPA is in there, FP 2030, DHS, MIX. We want to make sure that we're capturing not just the data that we have within CSI survey, but that we have other data to validate that and to use as controls to check on the results that we are getting. And the next slide, I believe I'm going to hand it over to you, Suzanne, and you can tell us about the Contraceptive Security Survey and take us through some of these results, right?
Great, thank you, Michael. So the Contraceptive Security Indicator Survey, sometimes you'll hear the CS Indicators Survey or CSI, was developed in 2009 by the USAID Deliver Project, and it's been taking place annually and now every 2 years since then. And so this data that we're going to look at is based on the 2010 through 2019 data sets. And we're currently working on our 2021 data collection effort. So this was a survey that was designed to, based on the SPARKS framework, looking at the different elements in the different sectors that were understood to contribute to access to contraceptives and availability and use of contraceptives. So based on the SPARKS framework, it was divided into these different areas. So the survey captures questions and variables under leadership and coordination, finance and procurement, commodities, policy, supply chain, pharmaceutical product quality, and private sector engagement. And the idea is that by looking at all these different areas, a country would be able to monitor its progress toward the concept of contraceptive security, which is the ability to choose, obtain, and use contraceptives as needed. And that it would inform policy decisions and program planning through this information at the high national level. But the issue, as Michael mentioned, is that we don't exactly know we didn't exactly know at which point, which of these policies were most likely to lead to the outcomes of interest, a high mCPR. So the data has been collected in every year in about 40 or plus countries, and in total, we have 62 countries that have been reported over the years. So in what we did, as Michael mentions, we took the 10 years of data that we had and aggregated it into this harmonized data set. But in addition to aggregating, we needed to harmonize a lot of questions that had changed over the years, coding them in a way that can be easily used for quantitative analysis, as well as creating some additional transformed indicators out of the existing indicators. So overall, we have this massive database of 342 country years of data. And I should mention this is available on the GHSC CS Indicators landing page. So now I'll go into some of the results that we saw in this top line study on policies leading to high mCPR. So this main portion of the study was looking at national policies from the CS indicators that correlated with an mCPR of greater than or equal to 51%, which we were considering high mCPR countries. We eventually narrowed it down to 51 indicators through processes of domain knowledge and eliminating similar indicators and through the statistical modeling process. And across all of these countries and the data that we had, we eventually were able to pinpoint 10 indicators or 10 variables that were identified by the model as both statistically significant in their correlation with high mCPR and operationally meaningful, meaning that they were able to, they're relevant and interpretable for use. So this is the list of the 10 policies that were identified. I'm going to go into them in the next slides as well, but here they are organized by what the modeler calls predictive importance. And that means the higher the predictive importance, the higher the likelihood that these policies will lead to or correlate with high mCPR. So all of these are statistically significant at least the the 0.05 level. But the most predictive were having an FP 2020 domestic financing commitment, a commitment to increase domestic financing for contraceptives. Secondly, having a higher share of funds spent by the government on contraceptives compared to donors, and having an LMIS, a logistics management information system that includes contraceptives and reproductive health commodities. So I'm going to go into these in a little bit more detail. So we kind of broke them down into these 4 thematic areas. The first was capital or financing. We saw that there were 2 areas of importance here, having a higher share of funds spent on contraceptives by the government compared to donors, and countries that were able to spend more on contraceptives as a percent of the forecast or the demand for contraceptives. So being able to meet the demand. In the second category, we looked at commitment or political will. And we found, firstly, the FP 2020 commitment to domestic financing of contraceptives was very important, as was the existence of a Contraceptive Security Committee. And for those committees, having a formal legal or administrative status. And finally, having a national strategy for contraceptive security was important. Third category we looked at was commodities. And this included having an LMIS that includes FP commodities. And then these 2 categories that we'll go into more detail on, which we really combined as one. And this is really method mix, having an increasing number of methods offered in the public and the private sectors were both found to be significant and correlated with mCPR. And finally, a grouping we called context. So we had commodities that having an increased number of FP commodities on a national essential medicines list was important. Having no duties applied to imports in the NGO sector in particular for FP commodities, and in general, we asked when asked about any sector, it was correlated, having no duties applied to FP commodities for any sector. So those are depicted here in this diagram where our outcome of mCPR is in the middle, and these are the 10 different policy elements. And as you can see, the policy elements as you get closer to the center are those that have a higher predictive importance, that are more likely, according to the model, to lead to high mCPR. Okay, I'm going to move to the second part here, which is now looking at, now that we know that method mix, we've confirmed again that method mix is a very important component of leading to higher mCPR. We wanted to look at, well, using the same approach, what policies would influence method mix. Or an expanded method mix is what we looked at. So here in this model, we looked at 52 indicators ultimately, or the model also narrowed it down to 52 indicators across the 62 countries in the 10 years. And with this data, the model identified 7 indicators as both statistically significant in their correlation with an expanded method mix and operationally meaningful. So those indicators, and I think we grouped a couple together here, are FP 2020 commitment. So this was having an FP 2020 commitment in general, not specifically focused on domestic financing, but just making an FP 2020 commitment. Having a Contraceptive Security Committee, and having a committee, in this case with a policy developed, which was sort of a way of saying that there has been action on the committee. The committee has been implementing what they had planned. Having a national contraceptive security strategy in place. We saw that with the initial indicator. And also, somewhat surprisingly, having clients charged for public sector services for FP services. That one we're kind of want to look into a little bit more, but that was an interesting finding, as well as, again, the increasing number of commodities on the National Essential Medicines list. So what was a little bit surprising here was that we didn't see a lot of financial policies leading to a higher expanded method mix, whereas we did see these policies correlating with higher mCPR duties, government share of funding, funding against the overall forecast or demand. So that was something that we are interested in exploring a little further. Why those financial policies were not important for method mix. And I think that takes us to the discussion. And I'll hand it off to Michael.
Thanks, Suzanne. Yeah, there's a lot to unpack there if people want. I would be really curious. Can you go to the next slide? So what have we talked about here? We presented national policies that are likely to increase modern contraceptive prevalence rate. Further, we've identified policies that lead to increased contraceptive choice, public sector product availability, which again corroborate, as was done previously, leads to increased mCPR. What's potentially interesting about this data set now is that while we've corroborated that, we really are now able to go back and say, okay, so we're starting to build a picture here. We know that method mix leads to mCPR increase. We now have evidence of other policies that lead to method mix. And again, we're trying to piece together a lot of things that already are being done, but for which there is not the type of evidence I suppose often I'd like to see. A lot of it is anecdotal or very specific to a country or region. So this has been really interesting for us to dig into. Keeping in mind that in this world of very limited resources, we have to inform the most efficient and effective strategies and have the evidence to back that up. What can we do that would most likely lead to success? If you've got to make a choice between things, that's what I think we're able to help with here. So next slide. What we want to do now is put it out to you guys if there are questions, and I just want to make sure I also remember to thank a couple other people who are on this team with Suzanne and I, Arthur Ostrega, Adam Dorius, who we both work with at GHSC-PSM, and then Mark Singbagba, who is a Ghanaian statistician who has been just phenomenal, sort of pulling us through the muck of the numbers and making sure that we're going in the right direction. So and also on our USAID side, we have Jane Mwange and Denise Harrison and Wazy Wintali, who have been really supportive, and so that has been terrific. So if there are any questions, we wanted to leave time, and please shoot.
Yeah, thanks, Suzanne. Thanks, Michael. Great presentation. And we do have a few questions that have come across the chat. I guess the first is from our own Milka, who is suggesting that we start thinking about changing married women as a variable. Unmarried women are having same or more sex than married women. Not sure if you want to take that one.
Yeah, I mean, you can't argue that. Milka, I agree. And there are others that I think forever I've been asking those things. I know within a meeting yesterday that FP 2030 convened for a performance monitoring group. It also came up, and there are others that do look at specifically unmarried women. We sort of towed the line here. This is where our data kind of comes from, and the U.S. government has been pretty steadfast here. So, but yep, I agree with you. And we can open that up maybe down the line.
Yep. I think also from Milka, question about, let's see, it says, when USAID graduated most Latin American countries of FP assistance and contraceptive donations, the first thing that disappeared in the countries were the contraceptive security committees. I'm not sure if that's actually a question or just a general statement, but it sounds like based on your findings that's maybe not a good thing.
Well, yeah, and that's very interesting. So, and Milka, we've actually had, I think, taught something like this. There's definitely, I think, a thinking among a lot of countries that, contraceptive security committees are the, contraceptive security 101, right? That's the first thing you do, and it gives you a boost up, and then you don't have to worry about it. I think what we're showing here is they may serve a different purpose than simply kind of convening and getting people connected to do that. And there is a strong correlation between maintaining those committees and a higher prevalence rate. So, it's interesting that happens. And your point may have been more like, well, that's great. You get up to that point, you have the committees, you're doing well. The assistance goes away. We can't afford the committees, and I think there's a number of dynamics at play here. But knowing the role they play, at least can contribute to the decisions then, that are made following it.
Thank you, Michael. But my comment was more than that. I think that because the contraceptive security committees have disappeared, that's why we see in many countries that mCPR has plateaued, and because there is no contraceptive security committee. So what I'm trying to say is, I agree with your conclusion, and probably this is something we need to work more in LAC to put back those contraceptive security committees, because they do have a lot of value, and your research is demonstrating that. So I will use your research to try to convince governments to put them back again, right?
Terrific. Oh, that is great to hear. Yes, no, I agree completely. We have not been able to find any studies that show that, even though probably millions of dollars have been spent on it. I was happy to see that this came up, given that. And hopefully when we do publish this soon, you'll have that in your back pocket. But
that's true. I should add, though, as you go up, we did briefly look at, instead of 51%, if we go even higher on the SCurve and to 55% mCPR, we did see that committees were not as important at that level. So there may be something there.
Yeah, I think there's something there. I mean, this is, like I said, this is research we're still trying to, weave our way through as we move up and around. I personally, I think that may be more of a factor of what Milka is saying, that, as we know, contraceptive security committees are important. We've now demonstrated that. And if they go away once prevalence goes up, if I was a betting man, I'd say Milka's probably right that either the funding goes away or people don't feel they need it anymore, so it goes away and then it plateaus. it might be interesting to look at two subpopulations that have gotten to that point and one goes away and one stays, and does one plateau and one go up, these are the kind of fun questions we now get to ask instead of just saying, yeah, it's probably works, let's keep doing it. And then if it doesn't work, stop doing it will be our recommendation, but we don't think we're going to say that yet. So thanks, Milton.
Good. So let's see, we got a couple other questions. One from Susan Papp from Women Deliver. We have
that's a good one.
Yeah, can you see that? Was there
a government spending threshold, a percentage of government budgets where you found the impact on mCPR to be a tipping point? That is a great, so that is something that we're about to start looking at. We are going to be we're going to try and find, I sort of think of it like a dose response, like you would for a pharmaceutical, right? How much do you need? And, there may not be an LD50, but perhaps there is that tipping point where we can go higher. Would love to be able to get that, and then we can start looking at efficiencies along with these. And I'll throw another one out, if I may, that we are also investigating now. And that is, so what we want to look at, what we've done is essentially look at two populations of countries, one that have a lower mCPR, one that have a higher mCPR. And we're comparing the policies versus where they stand, right? I mean, it's very simple in some respects. However, we all know that a policy takes some time to have an effect, right? If we have a contraceptive security today and we measure mCPR and it's low, well, yeah, of course. But if you measure it a year from now, after instituting the committee, it may be higher, right? So there is some, in addition to this dose response, there's also a time for it to be effective. And so what we want to look at is, Susan, this question that exactly like you've asked, how much is needed and how long does it take for it to be effective? And so we'll be doing a time lag analysis on this data as well to fill in some of those gaps. Did you look at government-sponsored efforts to drive? No, we didn't do that. We didn't look at other activities that were happening at the time. It's something that we may want to do, both because we might be interested in what specific activities work best on a sort of meta analysis, but also to see that wasn't necessarily driving some of the results we have. I mean, we'd like to take those out of the equation if we are specifically looking at policies. But as a former lab scientist, I really miss working in a laboratory with really controlled stuff, and the world is very messy. So I hope we can do that. And Suzanne, yeah.
Yeah, so that actually, so this year, since we'll be further adding another data set, the 2021 survey, we'll also be able to look at some questions that we had just started asking in 2019, and now we have 2 years of data for that. So one of those questions was about behavior change, communication, social marketing, different activities like that the government is doing to drive demand. So that we may actually be able to add that to the model.
That's true. Yeah.
Yeah.
Well, I hope we answered that. Any other questions?
I was just, I'll just say that I was pleasantly surprised to see domestic financing of contraceptive commitments, that there was a predictive importance of that, or that maybe that was even the highest when for policy determinants of mCPR, if the country had made an FB 2020 commitment related to that. I'm sure FB 2030 would be very happy to hear that, and certainly something that we're working a lot on at the coalition. So just, I guess, wanted to kind of point that out again, that seems to be one of the highest determinants of mCPR, and that I guess was just a demonstration from the country that it was something important and that they were all moving towards the same objective.
Yeah, no, Brian, it was. I mean, so the country financing, the share of domestic financing was very high, and that was more like. I guess I breathed a sigh of relief because it's something, you know, people have been promoting for years and years and years, and with the expectation that if you do this, this would be the result. And so this was really, I think, important to see. The fact that the FP 2020, you know, signing on to that commitment, just doing that commitment, it was by far the most highly correlated thing we looked at related to higher mCPR. I was not surprised. I was a bit surprised at how strong that was, and I think there's a lot to be said. You know, I don't think it's. I don't know what, you know. I'd be curious to hear what people think, but I think it's almost the, you know, there's an understanding, right, that intention is the most. You know, is the best predictor of behavior, right? It seems to fall within that context, but fascinating. Yeah.
Yeah, well, I can tell you that I'm on this small group that's reviewing a lot of the commitments that are coming in for FP 2030, and certainly domestic resource mobilization is a strong component of all of them. So I'm glad to, just glad to see that.
It's breathing a sigh of relief there. I am. Let me read maybe the next one. Interesting that charging clients for FP services correlates to greater method mix. Yeah. Will we be exploring this further? Yes, I think so. I have my own sort of personal theories of why. You know, at first it was a bit surprising, but to me afterwards it went, yeah, that makes sense. You know, there's a reason why social marketing works, you know, even if you're just paying a penny, it makes one perhaps want to feel, or it makes one feel more ownership, and maybe they're demanding more, maybe, but it is very interesting. I could talk about it for hours, and I know nothing about the reason why, but yes, we'll look into it.
Mm-hmm. Yeah. We're adding an indicator onto the harmonized data set about access to, about the cost of services and commodities through looking at both charges and insurance coverage, a combination of whether clients who are charged are also covered by national health insurance. And so they may get further into that. Whether there are exemptions for those who can't pay, that was a question as well.
Right. I mean, I'd hate for that one finding to all of a sudden lead to, you know, some sort of, not that our research is going to change the world, but I mean, you know, that people go, oh, well, then let's charge a lot more without those considerations, right? I mean, it is, there's a reason why social marketing exists within the context of the free and the commercial, public commercial sectors, and that would have to be done very carefully.
Yeah. Let's see. Do we have any other questions? I don't think.
If not, I can also say, you know, please feel free to contact us. I think our contacts are, well, there's one up on the screen now, and we're happy to talk or have any questions people have. Yeah,
let's see. I think, oh wait, we've got maybe another question from Ben Bellows. I don't know, Michael, if you can see that on the screen there.
Yeah, oh yes. Just a comment. Yep. Yep. There are people, you know, I'd love to have talks with you know, the private sector, the people who are looking at those. I've always been interested in boundaries in terms of, you know, where certain areas meet. You may have public, you may have social marketing, and then there's commercial. But in those areas where they meet, you have these issues that come up, and that's where chaos reigns, and it's important to really understand the dynamics there. So this may be the start of at least us thinking about that. Having spent the summer reading about chaos theory, you see this keeps coming up now. Dangerous what books I randomly pick up. So
Good.
yes,
Well,
thank you.
Yeah, if there are any other questions, please do feel free to speak up or put those into the chat. As was said, there isn't. If you do have some questions that you'd like to pose directly to the Susan or Michael, there's an email there that you can use. I don't know if you two, if there's any last comments you'd like to share before we wrap things up.
Suzanne?
No, just yeah, we're really excited about diving further into this data because, as we mentioned, this is just sort of a top line initial analysis that raises a lot more questions that we're now looking into, and we're very excited as well about having additional data from 2021 to be able to add to this. So
yeah, I'll echo that. I mean, again, thanks to our USAID supporters who I think went out a little bit on a limb. This is not the typical. I think we've been gathering this data for 10 years, and they were really supportive about now let's dig in and do this analysis. So it's been fun working with them, and everybody else has been part of it. So appreciate it, and thanks for listening to us.
Yeah, and there is one last question there. It looks to be about dissemination and the use of the results for advocacy. I don't know if you want to just kind of touch on that before we wrap up.
Yeah, this is actually the first time we've talked about this outside of our sort of little groups. And we do intend to write this up and publish this this year, and we'll be probably looking for other people who find this interesting, and we'll get it out. We do have a brief that will be putting around. It will have sort of the bulk of this data without going into the weeds that our paper will, but we will get it out to you. Denise, I see you have a hand up.
Yeah, hi, good morning. I've been having some IT problems, but I do want to say on behalf of USAID, a big thank you to PSM and a big thank you to RHSC, and we really are glad to have this opportunity to present this initial data and research, or to say, research because the data has been out there, to the SSWG and also members of USAID. We've got people from the Family Planning Strategic Position Group on the call too. So thank you everyone, and we really do hope you can participate and work with us as we dwell further into this analysis.
Thanks, Denise.
thank you.
Great, thank you, and thank you everybody for your time. And I'd like to say a particular warm thank you to Suzanne and Michael for a great presentation. It's great to see this information, and I think, as we said, this will be available on our website very soon, the recording, so it can be looked at again and shared if necessary. And if you do have questions, please do share those with Michael at the email listed there on the screen. And I wish everybody a good rest of your day wherever you are. Thank you very much.
Thank you.